Thank you for that welcome, Frank. It is a wonderful privilege and honor to be with all of you today. So much of the work that is done in this institution is part of the inspiration also for much of what we do down in the tip of the African continent. So it really is wonderful to be with you. As Frank mentioned, we are based at the University of Pretoria in South Africa. That's where I spend most of my time. We are an official WHO collaborating center, the only one on the African continent. We need more. There's so much work that needs to be done. And I think as I mentioned, as Frank mentioned, there's so much translational work necessary to really come up with solutions that can address the massive inequalities. So we really have been working hard at almost innovating out of necessity because there's such a massive need on the continent of Africa. So as I get going here, I think it's important just to acknowledge some of the valued colleagues and institutions that we've been working with, and also a whole team of postdocs and doctoral students who've been invaluable to support our research efforts. Also, just a note on the funding support. Frank mentioned some of those. Just listed at the bottom, the NIH has been an important partner. And then a disclosure, as Frank also mentioned, I am a co-founder of the Hearings Group, a digital hearing health tech company that works on solutions to provide hearing healthcare at scale in a decentralized manner. So maybe just the outline for today's presentation, very briefly. I'll look at the access to hearing care, the global challenge. To many of you, I'll be preaching to the choir, but it's good just to have the context and the stage set for the service delivery innovations that are needed, and also some of those that we've been working on over the past few years in terms of technologies, but also using task shifting approaches in communities. And then I'll spend most of my time on discussing some examples. So the first example will be on consumers and the OTC hearing aid effectiveness. Some of the work we've done there recently also just become available. And then we'll look at how those technologies can actually translate into low-income communities in feasibility studies to look at the impact of that work. So from a global perspective, the World Report on Hearing has been a wonderful asset in terms of information to set the stage for the importance from a public health perspective to really look at hearing loss. So the WHO estimates for the prevalence of hearing loss of 35 dB or greater, which they refer to as a disabling hearing loss, is 5% globally, which means there's 430 million people who require rehabilitation services. And that number is increasing rapidly. So by 2050, it's going to almost double to 711 million. Importantly, 1 in 4 persons over the age of 60 years are affected by disabling hearing loss from a global perspective. And from our point of view, what's really important to note is that more than 80% of these affected individuals live in low and middle income countries around the world, where services are really difficult to access if they're available at all. So according to the WHO, only 17% of people who can benefit from hearing aids are actually getting them around the globe. So it's not surprising that unaddressed hearing loss comes with a very big price tag at $980 billion annually. So if we just kind of break that down a little bit more in terms of uptake of hearing healthcare services, according to the WHO analysis, in the Americas, North and South America, the uptake is 17% of people who can benefit from hearing aids actually use them. If you look at Africa there, it's 90% that are not taking up or accessing hearing health care. But I've also put on the data from another study that came out recently that re-looked at this data from the WHO, but they also looked at hearing aid sales from industry, the bilateral percentage of fitting, or the percentage of bilateral fittings, and they looked at the lifetime of hearing aids to see if they can narrow down these numbers a little bit more. And they came up with a global coverage of 11% of people who need hearing aids who actually get them. In the Americas, the coverage was 22%, and here I think they're more accurate than the World Report, indicating that in the African region, the uptake is 2%. So that's just a totally untenable situation in terms of equitable access to hearing care. And of course, we know there's this strong positive correlation between gross national income per capita and coverage of rehabilitation and hearing aids. But since we're in the US, if we take a little bit of a US-centric perspective, this is from a recent paper that just came out in the last 2 weeks in Trends in Hearing by Larry Humes. And they looked at the US population data on hearing loss, trouble hearing, and the hearing device use in adults from the NHANES data over the 3 cohorts. So according to this study, they have excellent findings. I'm just highlighting some of them to make the point here. So 52.5 million US adults aged over 20 years, 22.4% of the population, have perceived hearing trouble. And that compares to 47 million based on pure tone audiometry cutoffs. So there's a 5 million disparity there. And according to the OTC regulations, that means all 52.5 million should potentially be considered as candidates for OTC assistance. But these data also show that 85% of US adults with hearing difficulties who self-report them still have unmet hearing healthcare needs. So again, the uptake and access to hearing health interventions extremely limited, even in a high-income country like the US. So the access challenges are multifaceted, and they include many different factors. We've heard about some of them this morning already. The scarcity of hearing healthcare professionals from a global perspective is one of the major contributors. In low-income countries, just to illustrate this, in 78% of low-income countries, there's less than 1 ENT for every million people. It's even worse when you look at audiologists. So in 93% of low-income countries, there's less than 1 audiologist for every million people. So if you think back to the prevalence statistics and the number of healthcare professionals, it's just an impossible situation to deliver care in the traditional manner. Even in the US, there's a shortage of hearing healthcare professionals, as you know. A recent study also showed that in 56% of US counties, there are no audiologists, and it's especially true for lower household incomes and older populations. And we also know that for racial and ethnic groups, minorities, this disparity is even worse. So most US hearing aid users are white, middle income, or higher individuals. But there is also other challenges to access to hearing healthcare. So the traditional centralized service delivery model for hearing healthcare based in clinics or hospitals or with soundproof booths, expensive equipment, has just been a barrier for widespread uptake of services. The prohibitive costs of clinical technologies, both the diagnostic testing, screening, but also the treatment, has been a major barrier to uptake of hearing healthcare services. And then there's the compounding effect of a lack of general awareness, knowledge about hearing loss, and then the nagging issue of social stigma that we still see very prevalent in hearing loss and with the use of hearing aids. So that's really why we believe service delivery innovation is essential to come up with decentralized, scalable solutions that can reach the majority of people affected with hearing loss. So these innovative approaches require, in our view, combining and leveraging the advantages that technology and connectivity offer us in combination with service delivery innovations, finding new ways to reach patients where they are at, and using health promotion strategies that can really get to people at scale. So the digital technologies can enable community-based care, and we believe combined with task shifting, they become powerful enablers to really reach people. But that also has an overlap with consumers. So consumer access, particularly with the OTC hearing aids, is one of the strategies, service delivery wise, that can rapidly decentralize access and do that at scale. So the research focus of the work that I've been involved in over the last 10 years has been really to look at how do we decentralize hearing healthcare access through digital solutions and leveraging the power and the speed at which digital solutions are advancing by offering them to anyone and to use anywhere. So the whole idea is that it should be simple enough for consumers to use, but it should also be simple enough for lay health workers to be able to operate these technologies. So we've been doing work on the screening side, the clinical side, now also the treatment side. So on the screening component, the whole idea of using mobile technologies for calibrated headsets to do mass screenings for children, for example, through a lay health worker, which you see illustrated in that picture. We've also worked closely with the World Health Organization to produce the YearWho app, which has now been used by almost 500,000 people in 191 countries around the world. And then, of course, also clinical testing that can take tests outside of traditional settings, outside of a booth, where you can utilize a smartphone to do air conduction, pure-tone audiometry, a video otoscope to do a visualization of the eardrum and even classify the type of ear condition the individual has. But for today's presentation, I'm going to be focusing on the treatment aspect and how we utilize these technologies to provide treatment in new ways outside of the traditional settings. So in terms of the way I'd like to do the next portion of this presentation is to look at consumer-based technologies first. So particularly self-fitting over-the-counter hearing aids compared to the traditional hearing care professional fit hearing aids and the service delivery models linked to that. And I'll share a randomized controlled trial and some real-world survey data related to that. And then we'll move back into the community-based model with the same technology in an African context and look at how through a community-based model with community health workers, we can enable new service delivery models with those technologies and the task shifting. So just some background around the OTC hearing aid research. We've seen a number of studies in the build-up over the last 10 years come out. So some proof of concept studies actually date back almost 10 years. So we have data on usability and factors of success for self-fitting devices. A lot of the work that was done by Liz Convery in Australia in the early days. We also have data on the accuracy of in situ hearing tests, doing audiometry through a hearing aid and then fitting the hearing aid based on those results. But none of those studies were on current commercially available devices. We also have data on the device performance, so electroacoustic quality of these over-the-counter hearing aids, and there's mixed results. Some show good results, most don't. We also know that price is correlated to quality, so the more expensive, the better the quality, typically, not always. But again, this work is not on the currently available OTC devices. In terms of surveys, very little survey data available on the perceived benefit of OTC devices by consumers. There's older data from MarkTrack and HEMA, but limited real-world studies and none on self-fitting hearing aid technologies at the moment. In terms of effectiveness trials, very few published data. There's the work by Larry Humes that looked at preset hearing aids, showed promise in terms of the outcomes. And then there's the work by Andy Sabin from Bose, looking at their self-fitting technology. But none of these studies looked at the considering post-fit support as part of the service delivery model. So that's where I'm going to focus today, is try to make a little bit of a contribution towards the limited real-world studies in terms of surveys, and then RCT effectiveness and considering post-fitting support. So if we look at the first study, which will be the randomized controlled trial, this is a clinical effectiveness trial that we conducted. It was a parallel two-arm design with a self-fit condition. These slides progress by themselves sometimes. So there's a parallel two-arm design with a self-fit and an audiologist fit hearing aid groups. It was a non-inferiority design. So we wanted to see, is the self-fit giving us the same results as the audiologist fit devices. So here we have, let me just see if I missed anything. So there we have the 93 were assessed for eligibility, 68 included eventually. And as we lost some to follow up, we had 32 included in both groups. So in the self-fit and the audiologist fit group. So in terms of the OTC hearing aid and support, we use the Lexi Lumen device, which is an over-the-counter self-fitting FDA-approved device. The cost of the device is reflected there, just less than $800. In terms of the actual technology, it's a 16-channel wide dynamic range compression device, so a digital, has good features, Bluetooth, adaptive directionality, noise reduction, and it has an accompanying app. In terms of the self-fitting approach, it includes app-based instructions that are followed by an in-situ piezo audiometry self-test conducted through the app at 500, 1,002, and 4,000 kilohertz. So we get a little bit of an audiogram across those 4 frequencies. And it's then self-fit based on the NL2 fitting algorithm, but with a proprietary comfort fit adjustment that's performed through the application. So that brings us to the OTC hearing aid and support component of this self-fit arm. So the app users can actually set the volume, they can set the environmental programs, the wear time is logged, so there's data logging of the wear time in the app, and you can check the battery life. But we also, in the application, there's a rewards program, and this is a behavioral incentivized program to help users wear their hearing aids. So this program includes them participating in training and giving feedback of their experience of using the app. It also has personalized wearing goals, so they can see, have I reached my goal in terms of wearing the hearing aids for 8 hours a day or 6 hours, but it's personalized according to their own requirements. In terms of activities, it includes things like acclimatization exercises, support, device care activities, ecological momentary assessment feedback, where they provide feedback on their experience in different situations, and then some outcome activities. Importantly, it's not just a device, but there's a service that's linked to it. So through the app, they can connect through video or audio calls to a Lexi expert, and they can also make remote adjustments if there's a sound quality issue. So they can, through a telehealth type of approach, make adjustments to the actual hearing aid. So that's just to give you a sense of what the self-fit group looked like. The audiologist fit group had exactly the same device, but it was fit by an audiologist from a fitting portal according to best practice guidelines. So the self-fit group was user-directed. There was no audiologist assistance. They could have the help of a significant other if they brought someone with them to the session. The audiologist fit group was selected. The audiologist was involved here. They selected the materials and they programmed the device. The hearing evaluation, it was only the in situ audiometry for the self-fit group. The audiologist fit group at the sound booth where they did a full test battery. The fitting prescription was the proprietary fitting algorithm in the self-fit group. For the audiologist group, it was according to the NL2 fitting algorithm, and within 5 dB tolerance limits of real ear measures. So the orientation for the self-fit group was through the regular instruction material that accompanies the device, the animated app instruction, and the user manual. For the audiologist fit group, they provided the orientation and the user manual to the consumer. And then there was a follow-up provided in both these groups. So the self-fit group had to contact the call center through the app, and the audiologist fit group could consult the audiologist at any time if they required any support or changes to the device. So just to run you through the design, so we had a baseline test session, and then they were randomized into the 2 groups. And then we had a hearing aid fitting session, which was the first session. And then there was a 2-week field trial. So during that 2-week field trial, no adjustments could be made in either the self-fit or the audiologist fit group. So that 2 weeks of wear time. And then we had the first follow-up 2 weeks later, P1. We did some measures at that point. And then there was an additional 4-week trial. And now they could contact the call center or the audiologist to make changes to the fitting. Our endpoint measures, the primary one was the AFAB. We also had secondary measures, which was the IOI-HA and speech recognition in noise measures, Quickson and the digits in noise. And we'll look at those in a moment. If we just quickly take a view on the participants, here you can see the audiologist fit and the self-fit group and their distribution across sex, age, hearing aid experience, self-perceived hearing loss, and the peer tone average. And you can see that overall, they were very similar between these two groups. So the average hearing loss is also very similar between the self-fit and the audiologist best practice fitting. So if we look at the comparison of the real ear targets and the measured real ear levels done at baseline, the first A and C, and then we have at 6 weeks at the end of the trial. So you can see for the audiologist fit group, the targets were really nicely met. And if you look at the self-fit group, there's a little bit of a drop at the higher frequencies. That was part of the proprietary fitting algorithm to cut out some of the high frequency amplification, make it a little bit easier for them to adjust. At 6 weeks, you can see that the audiologist fit groups real ear aided response was a little bit lower at this point. So that was due to the fine tuning and adjustments that the audiologist made to some of the fittings. The self-fit group was still very similar than their initial fit in terms of amplification. If we then look at the primary outcome measure, the AFAB, so we had 4 subscales: background noise, ease of communication, reverberation, and aversiveness. And we calculate the benefit as the difference between the unaided and the aided AFAB score. A higher score means there's more benefit associated with the two. So we determined the benefit at 2 weeks and then at 6 weeks. You can see it illustrated here on the figure as well. The interesting thing was at the 2-week measures, we found meaningfully better performance for the self-fit group on the global score and in background noise. But at 6 weeks, that benefit disappeared and there was equivalence. So the two groups were equivalent in terms of their outcomes. And you can see in terms of the distribution as well on the figure that they were very similar in terms of their benefit on the AFAB or primary outcome measure. So one of the secondary measures was the International Outcome Inventory for Hearing Aids, a widely used tool. We didn't do this at baseline. It's done once you have amplification. So it has 7 domains on a Likert scale. It looks at use, benefit, residual activity limitation, satisfaction, and participation restriction, impact on others, and then quality of life. And then you can also calculate a total score. And then we add all of these 7 Likert scale ordinal data together to get a total score. So if we look at the results for the IOI-HA at 2 weeks, again, we saw a meaningfully better performance for the self-fit group on 2 dimensions. Firstly, on the total score with a medium effect size, we saw longer hearing aid use per day after 2 weeks for the self-fit group compared to the audiologist fit group. But then when we redid this at 6 weeks, there were no differences. So the take-home message, as with the AFAB, was that there was equivalence in terms of the outcomes at 6 weeks between the self-fit and the audiologist fit group. We also did speech in noise measures. We did 2 measures, a Quickson, and we did the digits in noise. And in both instances, between the 2-week and the 6-week trial, compared to baseline, there was no meaningful difference in their ability to hear speech in background noise. So again, equivalence was demonstrated between the audiologist fit and the OTC self-fit group. So in conclusion, the self-fit group had meaningfully better outcomes at 2 weeks for their self-reported benefit. At 6 weeks, there were no meaningful differences in either of the outcome measures. So the specific self-fitting over-the-counter hearing aid with the remote support provided gives outcomes that are similar to a hearing aid fitted by an audiologist and supported by audiologists. There's, of course, lots more that needs to be done. The priorities are to look at the effects of particular devices and how that affects outcomes, but also the service delivery model and support linked to those devices. And then, of course, user characteristics. What kind of user characteristics influence outcomes? So much more work that can be done. This work has just appeared in JAMA Auto in April, so it's just off the press. You can access it there, but I'm also happy to email it to anyone interested. So that brings us to the over-the-counter versus hearing care professional fit hearing aid survey. So we did a survey to compare self-reported hearing aid outcomes for an over-the-counter and a hearing care professional service delivery model. So we wanted to look at real-world data to see what the benefit of users in the US in particular would be. So we did a prospective cross-sectional survey. Participants were invited from the hearingtracker.com community, and we also invited them from the Lexi Hearing user database. We used an online Qualtrics survey. It dates back to October and November 2021, and we sent this out through the Hearing Tracker database and to the Lexi Hearing Aid user database at that point. So the Hearing Tracker is an online, for those of you who don't know, is an online consumer forum that collects unsolicited reviews on hearing aids by members of the public. So the participants from this Hearing Tracker database were traditional hearing care professional service delivery participants. So they were assessed, they received the hearing aid and follow-up services from a hearing care provider, an audiologist, or a hearing aid dispenser, at either private hearing aid clinics, public health services like the VA, or discount warehouses like Costco or Sam's Club. The total survey ended up having 656 hearing aid users. 406 of them were from the conventional hearing care professional service delivery model, and 250 were from the Lexi hearing aids over-the-counter model. So the survey had 4 sections. We looked at the demographic and audiological related items. We also did the IOI-HA, but then we had open-ended questions on hearing aid experiences, and we also tapped into general health, well-being, and social networks. I'm only going to report on the first 2 sections in this presentation. So we did data analysis where we developed 8 regression models that had the IOI-HA as the dependent variable for total score, but then also for each of the 7 questions that had 7 different dimensions. So it's important to mention here that we were controlling for things like age, sex, duration of hearing loss, duration before hearing aid purchase, self-reported hearing difficulty, and unilateral versus bilateral hearing aid fitting. So just some of the demographics of these individuals that we surveyed, the HCP model and the OTC model. You can see the ages were significantly different between these 2 groups. The OTC model had slightly younger age cohort than the HCP model, maybe not surprising. In terms of sex, we're very similar, no significant difference there in terms of the distribution. The hearing loss duration, significantly shorter duration for the OTC model users than the HCP mode, and duration before hearing aid purchase quite similar, although there was a significant difference. If we look at the self-reported hearing difficulty between these 2 groups, we can see there that 69% of the OTC model said that they sometimes don't hear, compared to let me just say that again. It was 27% of the OTC model compared to 23%. And then we see 58% of the OTC model said they regularly don't hear compared to 47% of the HCP model. So in general, the hearing loss was reported to be more severe, more significant in the HCP model compared to the over-the-counter model. And that was a significant difference. Unilateral versus bilateral fittings, 4% of the OTC model had unilateral fittings compared to almost 9% in the HCP model. The hearing aid styles was behind the ear in the over-the-counter model, and then 9% of the HCP model had in-the-ear hearing aids. And if you look at the hearing aid brands in the HCP model, for those of you who know hearing aid brands, prescription devices, you know that those are fairly representative of what typically gets provided in clinics as a prescription hearing aid. So these are the results. So we looked at the 8 dimensions of the IOI-HA. One of those include the overall score. Maybe just important to highlight that there was only 2 factors that came out significantly different between these groups. So the overall score was actually the same between these 2 groups. Again, I think supporting the equivalence of the outcomes for these 2 different cohorts. But there was a significant difference for use of hearing aids. Even though if you look at the actual values, 4.7, 4.4, they're very similar, but the HCP model reported slightly more use in terms of duration than the OTC model. But in terms of residual activity limitations, it was the opposite. So the over-the-counter hearing aid users reported less residual activity limitations with their hearing aids than the HCP model. So let's just look at those 2 a little bit more closely. So in terms of daily use, you can see the HCP clients reported significantly longer hours of daily hearing aid use. That's the scale there. So those that reported they used their hearing aids more than 8 hours per day, the HCP model had a much larger representation there. And then at 4 to 8 hours, the over-the-counter model kind of balanced that difference out. Still high levels of hearing aid use generally. Kind of reached the ceiling effect there. So why this difference? Well, I think there's a number of reasons. It's conjecture at this stage, but hearing care professionals potentially emphasize use. We know it's an important measure as a typical indicator of benefit. And we know it is important, but I think there's also this concept of optimal hearing aid use. So hearing and communication needs versus just looking at an absolute time. Some users want their hearing aids for a very specific purpose, and it may be that they don't use it every day, but they use it for the purposes where it is important to their lifestyle. In terms of the residual activity limitation, the over-the-counter users had significantly less residual activity limitation. So the question here was, the difficulty you still have in situations where you most wanted to hear better. And the OTC group was 2.5 times more likely to have one category higher, in other words, less residual activity limitation compared to the HCP model. And again, this was independent of factors like age, sex, self-reported hearing difficulty. So why this difference? I don't know. The OTC model lends itself a little bit more to individuals who like to be in control of their hearing. So having an app to access remote support, do fine tuning. It may also contribute to a sense of independence, control, and self-efficacy. All of those things may be part of what's feeding into this difference. In terms of the overall outcomes and the conclusions, there was no significant difference between the OTC and the conventional hearing care professional models. Both show the IOI-HA outcomes also within similar ranges compared to studies that have been done in the US, Australia, the Netherlands, and Germany. So overall, really high levels of benefit across the IOI-HA dimensions. In fact, in many cases, it's higher than prior reported results. So the survey certainly confirms the RCT outcomes for this specific OTC hearing aid and service delivery model that's linked to it. Of course, there's a number of limitations to this survey. Whenever you're using two source pools, there's potential sampling bias that may have influenced this. But the results are available, just came out in the last 6 weeks in the American Journal of Audiology, and happy to also share that with anyone who would be interested. So that brings us to the community adult hearing care. So where we apply these technologies in a community setting to deliver devices, but not just devices, but support to community members. So here we set out to implement and evaluate a community model for end-to-end hearing healthcare in a low and middle income country, actually in particular in a low income community, facilitated by community health workers using mobile health technologies. So this was funded by the Assistive Tech Impact Fund in partnership with the Global Disability Innovation Hub. And the Eurix Innovation was our implementation partner in the communities. So what does this model look like? So very simply, this is a kind of outline of what the model, the basic components consisted of. It had community health workers deliver the care in communities across the spectrum. And we had a healthcare professional support this model remotely. And then we have mHealth technologies that enable this model across the 5 elements of this model. So the model consisted of detection of hearing loss in the community. We also had a component of diagnosing hearing loss, a limited diagnosis, actually a triaging type of diagnosis, just in terms of those who could benefit from hearing aids and those who required referral to for a medical workup. Then we demonstrated the hearing aids in the community. Then we had a treatment option for those who wanted after the demonstration to take up treatment. And then we provided support in the community through the community health workers using the mHealth approaches. So just a little bit of background on using mHealth and community health workers. We've been doing work where community health workers have been the primary providers of services for the last 5-6 years. But we enable them by providing technologies that are simple to use, but that really leverage this necessary quality controls to actually deliver a high quality service outside of traditional test settings. So we have done work where we looked at professional nurses compared to community health workers, testing hearing in communities and in schools. And we found that there's no significant difference between the outcomes where there's a professional compared to a community health worker who's been trained and using these technologies. We've also done this on the diagnostic equipment where we're determining thresholds. We did a work in Malawi with the London School of Hygiene and Tropical Medicine, and where we showed that whether it's a community health worker or whether it's an ENT or an audiologist, the outcome is the same because the test equipment is automated. And there's a rigorous quality control process linked to this. There you can see one of our community health workers in a home delivering and facilitating a service to a community member. We like to refer to this approach as a high-tech, soft-touch approach. High-tech because of we're really trying to leverage the advantages of technology and connectivity, but it's a soft-touch approach because we're using someone from the community who can actually mediate the service and provide it in the homes or the settings where these individuals are. That means a lot of the cultural language barriers are just not there. And it just opens doors to deliver services. So if we look at the first step here to detect hearing loss, we use a number of different strategies. So we have community screenings that's also conducted by automated mobile screening technologies. We partner with primary healthcare clinics and pharmacies to refer individuals who self-report hearing loss. And then we also rely on self-report community networks for the elderly who live and operate in these communities. So once they are self-reporting a hearing difficulty, we actually have community health workers who go to their homes, or we have days where they come into community centers where we provide a follow-up service to test their hearing. So in this particular project, this was the kit that the community health workers used. They had a pair of test Lexi Lumen devices with disposable ear tips. It was connected to a mobile phone. They also used a ear scope, video otoscope connected to that phone to do video otoscopy. And then we had a pair of Peltor earmuffs to put over the ears of these individuals. So the community health workers then did validated hearing aid in situ hearing testing. So they put on these test hearing aids on the individual's ears. They covered them with the Peltor earmuffs. They connect through Bluetooth to the mobile phone, and then they facilitate a hearing test on these individuals. Why do we use the Peltor earmuffs? Because it gives us a mobile soundproof booth. We can actually attenuate the sounds in the communities. So this is just the accuracy of the in situ audiometry done through the hearing aid compared to conventional audiometry. So we get about 93% of the thresholds within 10 dB compared to conventional audiometry when we use the hearing aids as our transducers. So here we have another example of a community member having the hearing aids on, the Peltor earmuffs over them, and the community health worker here is facilitating the test. So they don't need to know anything about audiometry. They are literally just pressing the button whenever the hand is raised by the community member. And the test is automatically conducted from there. There's just the attenuation that we get when we use these Peltor earmuffs. You can see the regular standard audiometric headphones, TDH50, is in green, and then the attenuation with the Peltor earmuffs, pretty much equivalent to a single-walled soundproof booth in terms of attenuation. You can really do reliable testing in someone's home or in other community settings. The second test they then do, if someone does have a hearing loss, they do a triage with a pure-tone audiometry and otoscopy. So they use video otoscopy with an AI classification linked to it. So this allows us to determine the hearing loss configuration, the degree, and the asymmetry. And the triage, sorry, this automatic slide carrying on. So we have a triage component. So we want to identify two groups, the one who can benefit from hearing aids and the other group who needs to be referred for ear disease, wax obstruction, or asymmetric hearing loss. So these results are uploaded to a cloud-based server automatically and is reviewed by the program manager, who's an audiologist, who can then do quality control and ensure that the referrals are done appropriately. So there's just an example of what the video otoscopy looks like. You can see there's a classification next to each of the images. There are 4 categories. The percentage is just the confidence level of the AI system. Here's just an example of where a normal eardrum is taken a picture of, and it then gives the diagnosis as normal with a 92% confidence level. So here's just some pictures to take you through the journey. There's a community member receiving the hearing aids. We put the Peltor earmuffs on, given them the instruction, the conditioning. They're pressing the button in this instance every time they hear the tone. And then we have the hearing check results displayed on the screen there. But the community health worker can then immediately program the hearing aid. So when they press that button, it programs the test hearing aids. When they take off the Peltor earmuffs, that individual can experience what a hearing aid can actually do for them. And what's great about that is it does this in a real life setting. So it's not in a clinic where it's quiet. This is actually in a home. So this particular lady actually had her granddaughter there. And when she heard for the first time in that setting, this was her first response. She said, "It is as if I'm able to see. Everything is clear." And it's remarkable just to see the types of responses you get from people when they are hearing in a real life setting. It's not in a clinic somewhere. And then they have the option to actually take up that treatment. If they want the treatment, a new pair of hearing aids are provided and programmed according to their hearing loss right there and then in their home. But of course, we know it's not just about the product, the device. There needs to be hand-holding and support for these community members over a period of time. So the community-based support is provided as the first line by community health workers. This includes things like the provision of the batteries, the disposables, but also the troubleshooting and the care of the device, providing information and answering any questions that they may have. So the community health worker can connect with the audiologist also for any remote support. So if there's something that they can't handle, they connect with the audiologist, get some feedback, and then connect back with the community member. So the main method of contact is through mHealth means, so SMS or WhatsApp, and that's the way in which the support is typically provided. There's also an mHealth acclimatization program that's linked to the service delivery model. So we've developed a series of 20 messages that are sent to these users over the first 45 days. And we've developed them to cover a multifactorial process of adjustment, handling the device, the maintenance of the device, cleaning the device, but also psychosocial factors about utilizing the device in community settings. The content of these messages include an info bite. Here's an example of what an info bite looks like. And it's accompanied by a voice note that's sent to them in the local language that's been recorded by the community health worker. So the voice note is about a minute or two long. It just talks them through the information on this message. And then it's scheduled to be sent over a series of days during these first 45 days after the initial fit. So in South Africa, smartphone penetration is really high. So more than 90% of households have access to one smartphone. So that's typically the way in which we present this information. If one person in a home has a WhatsApp account, we send it there. If none have access to it, we have a text message version of this. That's just a little bit of a dumbed down version of the acclimatization program. So I'm just going to share the outcomes of the first 19 individuals that we fit through this model. It's an ongoing program running currently. We also have in Kenya a small project up and running. The mean age was year for this portion that we're reporting on was 71 years. The hearing loss degree was a good spread between mild, moderate and severe. And here we have the IOI-HA again as our outcome measure, and we're reporting at 6 weeks and 6 months. And you can see the outcomes. 5 is the maximum. The outcomes are actually really good, and it's maintained 6 months down the line, which was really encouraging for us. There was a bit of a drop in daily use, but it was really well maintained over a 6-month period of time. So there's positive hearing aid outcomes and minimal device handling issues maintained at 6 months. In terms of the mHealth support outcomes, 79% received the program via WhatsApp, 21% via text messages. The participants described, we did a qualitative study to get feedback from the community members. And they described the program as helpful, supportive, informative, sufficient, and clear. 5 participants reported minor issues with the device, but all of those could be successfully addressed by the community health workers. So most participants receiving WhatsApp messages preferred the voice notes. So I think the voice note was a really easy way for them to consume the information at their own time and leisure, and they could actually refer back to it. So many of them said they listened to the message several times. So the mHealth program is feasible, and it can support a scalable self-management of first-time hearing aid users in low and middle income countries. And these results are published in a paper in Global Health Action, and the mHealth acclimatization program is currently in review. So that brings me to the conclusions to wrap this up and open it up for some questions. self-fitting hearing aids with remote support are showing that they can provide outcomes that are equivalent to hearing care professionals. In low-income communities, they can be provided by community health workers that are supported by mHealth technologies. And these digital health technologies, combined with task shifting, we believe are really powerful enablers for more equitable access to hearing care. There's lots more research that needs to be done. So the research priorities is to look at the varying influences and contributions from the device types, service delivery models, and the user-related effects. There's also important work that needs to be done on the contribution of a self-fitting approach compared to preset devices. Preset devices come at a lower cost point, they're easier to provide, and especially in low-income settings, that is an important strategy also to look into. The contribution of the support type and levels of support provided, and how important is that, and how much does it influence outcomes is important. And also the role of behavioral incentives to use your device. We think there's a lot of value there to actually have an interactive behavioral incentive for users to utilize their device and to have wearing goals that they track and get their necessary feedback. And then, of course, long-term follow-up studies is a very important focus for us to really see, do we still see these gains and benefits and equivalence across device types, 6 months, 12 months, 24 months down the line? And then finally, if we think of a low and middle income country context, cost effectiveness is still such a major concern that even the lower cost self-fitting technologies become expensive, and having batteries to replace becomes an expense. So looking at rechargeable solutions that are perhaps preset is an important next research focus for us. But we also believe if you want to kind of implement this at a primary healthcare level in a sustainable manner, we also need to look at financing models that allow users to actually get these devices at a price point or in a financial kind of model that makes sense for them. That's also why we believe the demonstration component of actually experiencing what a hearing aid can do for you is important in these communities. We've experienced that because once they've experienced it, it's amazing actually how community members club together to make it possible for their grandmother to have a device because they've seen the value that it adds to their life. So lots more work to be done, but it's an exciting time to be in this field. And thank you for the time to share with you a little bit of the work that we're busy with, and very happy to engage with anyone afterwards as well if there's anything else you'd like to know. So thank you very much.